The following podcast is part of a certified educational activity titled Navigating Recent Advances in Endometrial Carcinoma Treatment. Expert guidance to unleash the power of immunotherapy and other emerging therapeutic regimens. Access the entire activity and complete the post-test at peerview.com/RZJ860. Downloadable slides are also available.
Hello, my name is Anna Wagning. I'm medical oncology by training, and I'm heading the gynecological cancer program at Vall d'Hebron Institute of Oncology in Barcelona, Spain. Welcome to this educational activity entitled Navigating Recent Advances in Endometrial Cancer Treatment, Expert Guidance to Unleash the Power of Immunotherapy. I am pleased to be joined by my colleague, Professor Mansoor Missan, from the Department of Oncology, Rigshospitalet, Copenhagen University Hospital in Denmark.
Thank you, Anna. Thank you. And it is always a pleasure discussing these very important topics. What we have changed within the very few months, 1.5 years, we have completely changed the landscape of our patients' treatment, both in second line first and then in first line. By addition of immune therapy for the treatment of gynecological cancers. We are going to cover what these advances mean for our patients and share our perspectives for integrating their use in the clinic.
Excellent. So let us start with the objective and the goal for our meeting today. We want to increase your knowledge on the evidence supporting the current immunotherapy approach for patients with endometrial cancer. We will share some tips to navigate across all the new data that we are generating in the last year. And in addition, we hope to equip you with enough skills to make your decision in the treatment of advanced or recurrent endometrial cancer. So, let us start with some data, with some evidence in the epidemiology of endometrial cancer. What we know is that endometrial cancer is one of the most common gynecological tumors, and something that is quite important is the only gynecological tumor for which the incidence is still rising. You can see in the slide, in the figure, still we have a high number of deaths due to endometrial cancer. And what is the point? The point is that although the majority of patients are diagnosed in early stage and they can be cured with surgery plus minor tailored adjuvant therapy, those patients who are diagnosed with the recurrent or advanced stage, until now, they have a very poor prognosis. They have a 5-year overall survival around 70%. And why I have stressed until now? Because we have had a turning point in endometrial cancer approach. This turning point was the molecular classification. So the TCGA segregate endometrial cancer in 4 important molecular subgroups: poly or ultramutated, dMMR, MSI-H or hypermutated, copy number low, and copy number high. And what we know is that each molecular subgroup have a different prognosis. And in addition, they can lead to different therapeutic approach because they have different outcomes according to this therapeutic approach. And this is very important because the integration of the molecular classification in our practice guideline right now is guiding the way we treat our patient. And you can see in the slide, we have the NCCN and we have the ESMO guideline. In both guidelines, patients with endometrial cancer should have a molecular classification in their tumor. We need to know what kind of endometrial cancer our patients have in order to determine what is the best therapeutic approach for them. As I mentioned before, we need to know if the patient harbors a poly or not poly mutation in their tumor. If the patient don't have a poly mutation, then we go to the rest of the molecular classification, and the patient may have a deficiency in mismatch repair pathway or not having this deficient. For those patients without having in deficient in mismatch repair pathway, we need to determine if the patient have a p53 mutation or not. We carry out this molecular classification with the surrogate markers that are immunohistochemistry, because the TCGA, was the excellent classification, but they determine this kind of tumors according to the sequencing, molecular sequencing, and this kind of approach is not available for all sites. So, that being said, let's focus on the DMMR, one of the subgroups of the molecular classification. What we should know, what we should learn, is that endometrial cancer could be classified in those big groups. Those tumors who harbor a DMMR, this comprises 25-30% of tumor, and then those tumors without DMMR, that they are called PMMR of MSS. So let's try to understand a little bit more what does mean. Does mismatch repair deficient mean? We know that mismatch repair protein is DNA match pathway repair. When we have a deficiency in one of the protein that comprises this pathway, we have a loss of function of this DNA repair pathway. And then we have that the tumor is DMMR. And the DMMR tumor is the cause of MSI-H. Sometimes we exchange the terminology, but it's very important to understand that a deficiency, that the loss of protein in mismatch repair pathway causes an MSI-H tumor. And the main characteristic of MSI is that the high rate of mutation. And I would like to stress this because a high rate of mutation generates a high rate of neoantigens. And a high rate of neoantigens is the perfect environment to develop immunotherapy. We know that immunotherapy is changing the face of treatment of many solid tumors, and endometrial cancer is not different. Immunotherapy is changing how we treat our patient, and the most important is changing the prognostic of our patient. What do we stand right now with immunotherapy? We know that until recently, the backbone of first-line treatment was mostly carboplatin and paclitaxel, and I say until recently because we will learn later from Professor Mirza how this has been changed in the last years. However, for those patients who progress after platinum therapy, there was not a standard second-line therapy until immunotherapy arrived. Immunotherapy emerged as a game changer in the management of endometrial cancer. And then in interest of time, I will review only those drugs that have been approved by regulatory agencies in the US and in the European scenario. We have the pembrolizumab from the Keynote 158 trial, and we have dostarlimab from the Garnet trial. Both drugs have been approved for the treatment of DMMR, MSI-H tumor after platinum failure. And I would like to point out, in order to make the difference with the talk from my colleague Mansour, that this drug has been approved as monotherapy after platinum therapy. What are the data that led to this approval? For pembrolizumab, the data came from the Keynote 158. Just to refresh your memory, it was a multi-cohort trial, and one of the cohort enrolled patients whose tumor harbored a DMMR of MSI-H, and the patient must have received at least one previous line of therapy. The primary endpoint of this trial was overall response rate, and you can see in the slide, pembrolizumab showed a really compelling activity with an overall response rate of 50%. And very important, the median duration of response was 63%. Moving to the Garnet trial with dostarlimab, I should point out that the Garnet trial was a phase 1b trial enrolling different kinds of solid tumor, and I will focus on the cohort of endometrial cancer. The cohort of DMMR and the cohort of pMMR. Very importantly, the schema of dostarlimab was 500 milligram IV every 3 weeks for 4 cycles, and then we moved to a schema of every 6 weeks. Once again, the activity of dostarlimab as monotherapy in patients with recurring endometrial cancer after platinum failure was really amazing, showing an overall response rate of 45%, and with a median follow-up of more than 2 years, 27 months, I can state that 85% of the responders were still in response. So it's clear that immunotherapy works extremely well in those patients with dMMR endometrial cancer. But what about the activity of immunotherapy in those patients who had non-dMMR tumor, called pMMR tumor? As you can see in the slide, the activity is much lower. I mean, the maximum of overall response rate that we have observed was with dostarlimab, and the rate was 50%. So it means that there are room to improve. And one of the approaches that we have implemented to improve the activity of monotherapy is the combination of immunotherapy with another agent. We can combine with chemotherapy, we can combine with PAR inhibitor, and we combine with anti-angiogenic. Indeed, I want to review the data from the phase 3 trial, Keynote 775. This trial analyzed the combination of lenvatinib plus pembrolizumab in patients who have already received previous platinum therapy. And the patients were randomized to receive the combination of lenva-pembro versus a standard of care. In that stage was doxorubicin or weekly paclitaxel. Very important, this trial has a hierarchical analysis, first in pMMR, and then in the intent to treat population. However, since we are talking about the pMMR population, I just reviewed the activity in this group. As you can see in the slide, and you know very well, the trial met its primary endpoint. The combination of lenvatinib plus pembrolizumab was superior to chemotherapy in terms of PFS and in terms of overall survival. Indeed, the hazard ratio for PFS was 0.60. It means a reduction of 40% in the risk of progression. And most importantly, the hazard ratio for overall survival was 0.70. It means a reduction of 30% in the risk of death. Really an improvement compared with the standard of care. So, I mean, the first thing that comes to my mind is, due to efficacy of checkpoint inhibitor after platinum therapy, why we shouldn't move this therapy to the first-line therapy when we have a greater chances to improve the outcome for our patients. So, Mansoor, I think you are of the leaders in the field of endometrial cancer at immunotherapy. Please, would you be so grateful if you can review the data that are changing the landscape of the treatment of our patients with advanced disease?
Thank you, and a beautiful talk. And as it was a great journey. You have shown us how we have changed the landscape already by introducing immune therapy in the relapse setting, although in that case it was in the dMMR, and then we saw the combination with lenvatinib in the Keynote 775 0301 study, which showed in the pMMR population that if you combine immune therapy with other important agents, you will benefit more and you will have a real efficacy. So my topic would be radical changes in standard of care for recurrent and advanced endometrial cancer in frontline. You have very nicely introduced why and how immune checkpoint inhibitors work. And if we add chemotherapy to immune checkpoint inhibitors, we know that chemotherapy enhances immunogenic cell death and reduces immunosuppression in the tumor microenvironment. And also, if we add PARP inhibitors on top of that, that will add to immune checkpoint inhibitor may further improve the outcome. And I will try to review all these trials, what we have seen in the last 1.5 years, how they have changed our landscape completely. These are the major trials, phase 3 trials in first line, which are presented and reported, except one. I'll come back to that. So the first 4 trials here from the left are Ruby, Attend, NRG018, and EN11. These trials are asking one question: can we add immune checkpoint inhibitor on top of chemotherapy, carboplatin, paclitaxel, which was the standard of care, as you nicely told us, Anna? If we can improve the outcome of our patients, in all patients, both in the DMMR population and the hypothesis of combining chemotherapy with checkpoint inhibitors, that it will work better in the MMR proficient disease as well. The last 2 trials here, the Ruby Part 2 and Duo E, are asking a different question. That chemotherapy and added immune checkpoint inhibitors, once you have finished with the chemotherapy, if we on top of that add PARP inhibitors combined with immune therapy, are we going to further improve the outcome of our patients? And I will quickly run through the results. I would say that we have seen results of all these trials except EN11, which is in the middle. However, we had a press release a few weeks ago that that's a negative trial, which is sad. All other trials are extremely positive. And let's go through these trials. So if we look, what I have done is, progression-free survival in the DMMR. So first I will look at the DMMR population, and then I'll move to the PMMR population. In the DMMR population, when we look at the progression-free survival, you can see the hazard ratios in the second last line, where you can see the hazard ratio of 0.28 in Ruby, 0.30 in GY018, 0.36 in Attend, and 0.42 in Duo E. These are extremely positive, extremely positive. And then the most important thing is, can we improve survival for these patients? And that's why I have put Kaplan-Meier curves of survival curves in this slide, showing that all these trials are showing benefit when it comes to overall survival. The mature overall survival data, which was also the primary endpoint of Ruby trial, it comes from Ruby Part 1. And that shows unprecedented improvement, which is almost 70% risk reduction in overall survival. And look at the curve of that, the one on the left. It looks like that the events, very few events are occurring during the course of the disease during the 3 years, what we have about in this follow-up. And it seems like it looks very similar to what we see in the normal population, their survival when the median age is about 68. So what I'm trying to say is, probably, I believe that we have cured quite many of these patients, bringing the immune checkpoint inhibitors up front in first line. So no question, this is no-brainer. This is the new standard of care for patients who are mismatch repair deficient, stage 3, stage 4, or first relapse. These patients must be treated with chemotherapy plus immune checkpoint inhibitor. The next question we asked was, is there a benefit in the DMMR population of adding PARP inhibitors? I showed you there are 2 trials, and we have results of that. One is Ruby Part 2, another is Duo E. It is difficult for Ruby Part 2 to take any decision as yet, because Ruby Part 2 experimental arm has to be compared with Ruby Part 1 experimental arm before we can come up with a conclusion if there is a benefit of PARP inhibitors. But we can see in the Duo E, although the trial was not powered to see difference between the 2 experimental arms, but if you look at the progression-free survival, you can almost not see any difference between the arm B and C Kaplan-Meier curves. And that is telling us probably that's hazard ratio of 0.41 or hazard ratio of 0.42. So that is telling us that probably in the DMMR population, we are not adding any benefit by addition of PARP inhibitors. We also have to look at the Ruby data. Probably it will show the same difference. So this was the case for the DMMR population. If we conclude a tremendous benefit of addition of immune checkpoint inhibitors to chemotherapy, no extra benefit of addition of PARP on top of that. When we come to the mismatch repair proficient disease and look at the progression-free and overall survival, you see again there is a benefit, not that high, but there's still a benefit by addition of immune checkpoint inhibitors to chemotherapy. You can see the progression-free survival with hazard ratio of 0.76, 0.54, not seeing that benefit in a 10 trial, but also in 2OE trial. When we look at again at the overall survival, we have mature data from Ruby Part 1. And here you can see that there is 7 months overall, median 7 months overall survival benefit by addition of dostarlimab to carboplatin paclitaxel, telling us that yes, there is clear benefit of addition of chemotherapy, not that huge as we saw in the DMMR, but there is a clear evidence of efficacy in that case as well. Again, we can ask the next question, what about addition of PARP inhibitors in this subset, in the mismatch repair proficient disease? Is there a benefit? And if we look at the 2OE trial, here you start seeing the separation of the curves between arm B and arm C, both in the progression-free and overall survival. You see hazard ratio increasing from, getting better from 0.77 to 0.57 in the PFS and 0.91 to 0.69 in OS. So it seems like that patients who have mismatch repair proficient disease, it's there where you see the benefit of addition of PARP inhibitors to immune checkpoint inhibitors and chemotherapy. We would like to see the data of Ruby Part 2 as well when it is mature and we have done the analysis. So, potential benefit of PARP inhibitors and addition of immune checkpoint inhibitor and chemotherapy is there. There is significant improvement in PFS, but pending mature overall survival data. However, one should remember, we are adding a fourth drug. So how much overall survival benefit you would like to see before you start using that in the clinic? I would say that indirectly, if I compare how much benefit we have in the mismatch repair proficient disease by addition of only immune checkpoint inhibitor, in Ruby Part 1, we saw median 7 months of increase of overall survival by addition of dostarlimab. So if we are adding PARP inhibitor on top of that, I would like to see much more benefit before I use the 4 drugs in the treatment. So we have to still wait and see the data once it is matured. Another important thing is, especially for the DMMR population, it's no-brainer. It's a huge efficacy. We have also 2 trials showing both the GY018 and Ruby that in DMMR population, both patients who have the cause of DMMR is methylation or mutation, both are nicely responding to the treatment as strongly as each group. Now, when it comes to the mismatch repair proficient disease, where we see benefit which is a bit less than what we saw in DMMR population, it would be important to know which of the subgroup is benefiting the most. And the one way we can try to do that is if we look at the molecular classification and other biomarkers. So we did in the Ruby Part 1, which is on the left, we did the molecular analysis. And it was very surprising to see that the patients who had P53 mutated, disease. These are the bad prognosis patients. There we saw a very nice rising of Kaplan-Meier curve in the experimental arm by addition of dostarlimab with a hazard ratio of 0.55 for the PFS. When we look at the same in the NSMP, that is non-DMMR P53 wild type population, there you see only a modest increase. Why it is modest? There could be a couple of reasons. One can be that these patients are not really susceptible to immune checkpoint inhibitors, but we don't know yet why, because these are the patients who have very slow and event rate. It takes time for them to progress. So I think we have to follow up for a longer period to understand what is happening here in the NSMP population. When we added PARP inhibitor on dostarlimab, that is Ruby Part 2 on the right, although the numbers are small, you see all these subgroups are responding. Especially look at, I cannot I'm only excited, although numbers are very small, in the P53 mute population. What a hazard ratio, 0.29. So it seems like that we probably are nailing down which are the patients who are benefiting the most. Although these are the hypothesis retrospective analysis, we have to wait that other trials do these analysis as well. If they all show the same outcome, then this becomes reality. Then we can take the clinical decisions according to that. Until then, we can only rely upon our primary endpoints. And in Ruby trial, it has shown in the PMMR population median overall survival benefit of 7 months. So that is where we stand today. The next we asked was if PD-L1 is doing, can we use PD-L1 as a predictive biomarker? And we really did not find. The DuoE did the analysis, we did it in Ruby Part 2, and we don't see that any correlation to prediction. It is prognostic, but not predictive biomarker. The next what we did was, both in DuoE and Ruby Part 2, was look at the analysis of BRCA mutation, and not much. All patients are responding so well, so you cannot see the difference. In the Ruby Part 2, numbers are too small, so we can't see what is happening there in the BRCA mutated patients. When it comes to the HRR mutations, you can see probably there is a hint in the DuoE that these HRR mutations these patients are doing better with addition of PARP. We cannot answer that question in Ruby Part 2 again because the numbers are too small. So I think we are starting to learn some other biomarkers which may help us planning our treatment accordingly. Who are the patients who would be benefiting most from PARP inhibitors and so on. So the Ruby post hoc analysis of PFS, I already told you shortly about it. The PFS and overall survival by MMR protein loss. We have seen that these are the all patients who are responding equally if they're mutated or methylated. So if I conclude the whole thing and put it in the boxes, the patient characteristics in first line, and look at according to the DMMR and PMMR. In the DMMR, all patients are responding, extremely responding, unprecedented benefit by addition of immune checkpoint inhibitors. Now, addition of PARP inhibitor does not show doing any more benefit, and there is no difference between efficacy in patients who are mutated or methylated for mismatch repair. When it comes to the mismatch repair proficient disease, I did not show you the data on polyimmu. There are very few patients, but they do not progress. As I say, poly patients never die, at least of the disease. And this is great. And we still have to figure out, can we decrease the treatment we are burdened for these patients in future. But when it comes to the poly wild type in P53 abnormal, we see clear activity of addition of immune checkpoint inhibitors and class minus PARP inhibitors. In an SMP, the efficacy is modest. We still have to wait longer for the events to see the difference. So these are the trials which I showed you in the beginning, but there are three other trials which are asking a very important question. The question is, can we replace the conventional carboplatin paclitaxel with novel treatment? The three trials are, the first two here on the left are Keynote C93 and Dominica trials. These trials are only in the mismatch repair deficient disease, where patients are being randomized to chemotherapy, which is conventional standard of care, versus single agent immune checkpoint inhibitors. We have not seen results of any of these trials yet. The third trial is LEAP-1 trial. The idea of Keynote 775, which Anna very nicely presented, brought it in first line. So the comparator here is not single agent chemotherapy, but carboplatin paclitaxel. That trial was negative, and this is of course sad to see. So the take home message would be that we must do molecular profiling of endometrial cancer, because it has completely transformed our therapeutic approach. Checkpoint inhibitor plus carboplatin paclitaxel is the new standard of care for patients with advanced or recurrent endometrial cancer. However, there are many questions to be asked. This is just the start of this unprecedented era in the management of our disease. But we have to ask many questions. Who are the DMMR patients that do not benefit from immune checkpoint inhibitor plus chemo? Can we replace chemotherapy in DMMR? We are waiting for two trial results. And how do we treat patients who experience relapse post chemotherapy, and how do we further validate the prognostic value? Most important, the patients who will progress on immune therapy, first line immune therapy, how we are going to treat these patients after that. We are now planning the trials of in that situation as well. I think we have really changed the outcome of our patients, and today I feel that many of these patients are being cured.
Absolutely, Masur. Thank you so much for this nice review of the main data that are, impacting our standard of care and the outcome of our patient, that at the end of the day is our main goal. So I think it's quite important when we have a patient diagnosed with endometrial cancer in front of us to explain them what molecular classification means. I always explain to them that the molecular classification is a kind of last name. You can be called Anna, but if you don't have the last name, you can be the same as another one. So, the molecular classification is the last name of the tumor. Then I explain how important it is to have this molecular classification. Firstly, to understand better the kind of tumor they have, and secondly, and less important, to explain them the benefit that they may have of the therapy that we are going to propose. Because, you have explained very well, Mansoor, that the Ruby trial was positive for overall survival, and this is absolutely utterly nice at the change in our standard of care. But I also like to explain to my patient the benefit that they will get, the benefit that they may have. And to explain this benefit, I need to inform them what kind of endometrial cancer they have.
I completely agree. I think that is extremely important, that we discuss with patients what type of disease it is and how they will respond. Some of my colleagues are asking, now you have shown that all patients are responding to immune checkpoint inhibitors. Do we need molecular classification? Do you comment on that?
Absolutely. As I said before, so it's true that we have seen that immunotherapy is effective in the all comer, in all patients with endometrial cancer, but the benefit that the patient have from the immunotherapy is different according to the molecular subgroup that endometrial cancer has. So I think it's quite important to have this molecular classification to inform the patient the benefit that they may have from a particular therapy, because when they know the benefit, I think that they have much more adherence to the therapy.
That's right. I think these are the points we have to remember when we are discussing with the patients. But also very important is the patient safety when implementing these combination strategies. Can you, Anna, walk us through the safety considerations and practical tips for?
Absolutely, Mansoor. I mean, I think safety is a key issue or is a key point in the treatment of a patient with immunotherapy. Why? Because, I mean, in general, immunotherapy is very well tolerated. Indeed, when we look at the rate of discontinuation in all the clinical trials with immunotherapy, according to the safety, the rate of continuation due to the adverse event related with IO, this rate of discontinuation we can consider that is low, but exists, and there's patients that should discontinue therapy due to immuno-related adverse event. I think it's quite important to know the safety profile of immunotherapy. Why? Because there are 5 pillars to manage the potential immuno-related adverse events. And one of them is prevention, the second is anticipate, third is detect, 4 is treat, and 5 is monitor. I will try to summarize in a very brief manner. Before starting immunotherapy, both physicians and nurses, I said the healthcare providers, and the patient should know what kind of adverse events they may have. Why? Because it's very important to anticipate the development of this adverse event. Why? Because if we are able to identify early in the patient journey this kind of adverse events, we can prevent patients from developing grade 3 or grade 4 adverse event. And why this is very important? Because we are talking about the very effective therapy that we want our patient will be able to continue. And for sure, on top of that, because we want to prevent our patient from developing severe toxicity. So teach your patient, teach the family, and teach yourself about this side effect. And when you identify the side effect, it's very important to implement therapy as soon as you can. Once again, in order to prevent grade 3 or grade 4. You don't need, to know all the management in your memory. There's plenty of guidelines that you can follow to learn how you can treat this patient suffering from this immuno-related adverse event. But, as a kind of globally overview, I would say that immunocheckpoint can cause immuno-related adverse event in every single organ. And I repeat, in every single organ. However, the most frequent are dermatologic, such as rash and pruritus, gastrointestinal in form of diarrhea, nausea, and vomiting, and very common side effects are endocrine adverse events, as a hypothyroidism or hypothyroidism. And pneumonitis is not really frequent, but it could be severe. So keep in mind all these potential adverse events to identify early. So another thing that can help you in order to identify these adverse events is the course of this adverse event. Skin toxicity could appear very early in the course. Colitis should appear around 2 months of therapy, and something that is very important, endocrinopathy, hypothyroidism or hyperthyroidism may appear at any time. Test your patient for the thyroid liver function in every single visit that they may have. Mansoor has pointed very well that PAR inhibitors are also incorporated in the treatment of endometrial cancer, at least so far in the clinical trial. Hopefully, maybe, we will have also in the daily practice. Then you also need to know the common adverse event related with PAR inhibitor. And then we can break down in hematologic, anemia, thrombocytopenia, neutropenia, non-hematologic, that is called class effect for PAR inhibitors, such as nausea and vomiting, asthenia, diarrhea, or constipation. And then we have the called rare adverse event, but we need to follow up closely. That is acute leukemia, myelodysplastic syndrome, and pneumonitis. So I think we have provided you with a lot of scientific data that you can review in a carefully manner through the slide, but let's try to bring this data to the daily practice. And the best way to do that is through a patient case. So I will share with my colleague Mansour one of my patient case, and then we will discuss together in order to determine what will be the best approach for this patient. She's a lovely 54 years old Asian woman that she lives in Spain, but she's from Asia. She's suffering from diabetes type 2, and she has a very interesting family history. Brother diagnosed with gastric cancer, sister died of liver cancer, and a paternal cousin diagnosed with uterine cancer. She started with metrorrhagia, and then, she went to the primary care, the physician care, and then, very, very early, that this is verified, she got an endometrial biopsy. And then she came with this endometrial biopsy to our institution. Then we will review the histology, and then we identify, unfortunately for her, a well-differentiated endometrial carcinoma. And what was the next step that we have on this specimen? We went to have a molecular profile. Why? You may think, why in the biopsy? Let's wait for the surgery. No, you can. The molecular classification should be performed on the biopsy, because from the analytical point of view is much better. So Mansour, do you agree that we should have the molecular classification early in the patient journey? If we can have this in the biopsy, in the diagnostic biopsy, will be better?
Oh, absolutely. And I think this is very important topic you're discussing, Anna. We have to perform this molecular classification in the very beginning. If it is the biopsy, we have to do it in biopsy, because your treatment paradigm will be completely different in that case. You will be maybe diagnosing Lynch and have to go further. You will be in the endometrial cancer. You will be discussing how to treat that patient. And I completely agree.
Thank you, Mansour. I'm happy that we are on the same page. So then we perform the molecular classification, and then interestingly, we identify in the tumor that there's a loss of one of the mismatch repair proteins, indeed MSI-H. That, as you know, when you identify the loss of this protein, the patient should be referred to the genetic counseling, because in most of the cases, this is a germline mutation, and it means that the patient may suffer from a Leach syndrome. So always that you identify a loss of MSI-H protein, the patient should be referred to the genetic counseling. So our patient, she was taken to the operating room. After, review all the workup, we have a pelvic MRI when we identify the tumor into the endometrial cavity, and then we rule out metastatic disease. So the patient got a laparoscopy surgery, and I will point it out the most important finding. The most important finding was the histological type. It was endometrioid carcinoma. The myometrial invasion was less than 50%. There was not vascular invasion, we say invasion of lymphovascular space. And then we go to the status of the lymph node. The patient had a sentinel node biopsy that showed that it was positive, and then the patient got a lymphadenectomy. And interestingly, we identify para-aortic positive lymph node. It means that the patient had a stage 3C2 endometrial cancer. What we discuss with this patient is that there's different options for adjuvant therapy. We explain, the classical approach with the Porter-3. We explain, the GOG 258, just paclitaxel carboplatin. And indeed, we explain, because she's a very well-educated woman, we explain the exploratory analysis presented by the GOG 258 in the NSGO this year, where they show in this kind of post-hoc exploratory analysis that it seemed that radiation therapy didn't add any benefit in those patients with DMMR. And then finally, we explain the RUBY trial and the outcome. We explain that she should receive 6 cycles of paclitaxel carboplatin with concurrent dostarlimab every 3 weeks during this period. And after chemotherapy, she was still in complete response, there's not evidence of the disease, then she started a maintenance therapy with dostarlimab every 6 weeks. And then, the maximum duration of this maintenance therapy was 3 years, but we will have a very close follow-up in order to determine how she was tolerating the therapy, how the disease was under control, and then we explain the potential adverse events related with the therapy, and we explain also that the rate of discontinuation due to adverse event was very low, less than 20%. And then, she agreed with this approach, and then we have just started the first cycle of chemo with dostarlimab, and, she has an excellent tolerance, and we hope that, that she met exactly the same outcome that we have seen in the RUBY trial.
I completely agree. I think this is the same treatment we would be giving in my center. I would like to comment that we would not prescribe radiation therapy to patients with metastatic disease in the lymph nodes, because there is no benefit in survival. You are adding extra adverse events, and actually, with having such a strong benefit of immune checkpoint inhibitors, I don't see why we have to treat these patients. Some centers are still trying to do that, and I do not agree to that. And as you said, there is, yes, subgroup analysis, but what is in lymph node metastasis? That is a surrogate for distant metastasis. They need systemic treatment, not another. Your patient had a great local therapy surgery. She doesn't need another local therapy.
I cannot agree more with you. So, Mansoor, I still believe that for those patients with para-aortic lymph node, they should receive just a systemic therapy. And for sure, now with the data that we have from the RUBY trial in a DMMR patient, there's no brain that they should have received chemotherapy plus IO.
This was a great discussion we had, and in summary, we have seen the evidence that supports the use of immune therapy for treating patients with endometrial cancer, and learned effective approaches for integrating them into clinical care to support optimal patient outcomes. Thanks, Hannah, for a great discussion and great talk. I always get more informative after these brilliant talks you have. And I hope you all have also enjoyed our session, and it is useful for your practice. Thank you.
Thank you, Mansoor. It has been my great pleasure to be with you today here. I think we have reviewed in depth all the new data of endometrial cancer and how, the physician can treat this patient in a very safely manner. Thank you so much for being with me today.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/RZJ860.